Before Corby comes to the stage, he's going to talk about something, and I'm not trying to steal your thunder, called the Aspen Institute Research Action Plan. And you have heard mentioned several times today about a convening happening. And you're like, what? What convening? You all have in your packet the link to attend this virtually if you are not already part of the group that was attending in person. So this is not exclusive. You can register and join tomorrow and listen from the comfort of your home office or office. So this is in your packet in case you haven't been through all the pieces yet. It's an abbreviated agenda, and the link is right there at the top, so you can register even right now as Corby is speaking. So at that point, I'm going to turn the stage. Would you prefer tabletop or handheld?
Well, does the mic work? Great. First of all, I could not be more thrilled than to be working with Elizabeth and Mariana Wetherill, who was one of the original advisors that made this entire initiative work and possible. And nothing about what Food and Society at the Aspen Institute does is exclusive except the name Aspen. So that's part of the overarching name, and we're all aware of its connotations. But the main program work of the Institute, first of all, we're all in Washington. None of us who work there can afford to live in Aspen. It's completely out of the question. There's about 400 people at the Institute's headquarters in Washington, probably about 24 who work in Aspen, and they all have to drive 45 minutes to an hour every day just to get to someplace they can afford. It's a magical place and a beautiful campus, as Richard, I hope, will tell you, because he came to our first convening. All of us who convene there pay an absolute fortune to do it, but still it's unique and beautiful. But the real nuts and bolts of the work that the Institute does is all done out of with partner organizations, and it's all done from our headquarters in Washington. It was so fitting that Alyssa Wassung from Food is Medicine Coalition spoke to you right after lunch from the headquarters of Community Servings, because Elizabeth kindly came to a meeting that we held at Community Servings, which is how I myself got involved with Food is Medicine. I was a founding board member of Community Servings. I'm still on their board. She was speaking to you from a conference room. I worked hard to raise money to build. So I've been doing this for decades. I've been inspired by the work that the entire coalition has done, and Community Servings with its Food is Medicine Accelerator has been a prime mover in helping onboard new community-based organizations into what does Food is Medicine mean, how do you do it, and we're going to get to go forward thanks to our partners at Walmart Foundation who made this possible. Our next project is going to be a best practices hub, which we're really excited about, specifically around community-based organizations. So I'm so excited to meet a lot of you here today, and it's really thanks to Elizabeth, Brandon, Mariana, and lots of other people that I get to meet you. So just to introduce you to this plan, which is very easily available online, and Trina has been one of our advisors from the very beginning, and I'm not going to take too long so that we can hear from her, because everyone's more interesting than I am today. Do I go forward? And it actually works. Okay, so some of your names are right there. Incredibly generous people. So we had partners at the Center for Health Law Policy Innovation. The pyramid you've been seeing today was really the product of the Center of Health Law Policy and Innovation at Harvard's Law School. They've come up with a lot of very good ways of, first it was the pyramid. This is the idea of a house. What are the various parts of the house that has access to different forms of health care? So when we were thinking of the plan, we had to come up with some sorting mechanism. What constitutes a Food is Medicine intervention? And the idea was this is going to be the first comprehensive review of peer-reviewed research into nutrition interventions, those being medically tailored meals, medically tailored groceries, and produce prescriptions. So inside of the scope it has to have a nexus to the healthcare system. That really, it's listed as number 2. It's the overarching definition that we used. And it had to be the provision of food that supports health. So it's pretty much everything you've been hearing about today. But for the purposes of these studies, and we reviewed all of the studies that have been done, it was mostly the studies between about 2016 and 17 and 2020. That was kind of the first tranche, and when it was work was really getting underway, and that's what we surveyed. We came out in January of 22, but because of the pandemic, because a lot of work was paused, really our studies went up to 2021 at the most. And now, excitingly, in April, we're coming out with a second edition, which I'll be talking about. This is to introduce you to the first edition. So in scope of all the programs we've been hearing about, WIC is a shining example. And many of you work with WIC or on WIC? No, I'm not seeing hands up. It's really a very effective food as medicine intervention and program. So these are things you can all see online, but the main categories were medically tailored meals, medically tailored groceries, which includes meal kits, meal deliveries. So many of you work with this kind of delivery. We're hearing from Melissa about the exciting opportunities in delivery. That would be for medically tailored groceries. Really promising data coming out of medically tailored groceries, because as you see from the pyramid, medically tailored meals are the most expensive by far of all of these nutrition interventions. And here they are. Here are our definitions. Again, these definitions look simple, but it's gathering them from many different rival definitions. So here's what we came up with, and we think it's concise and kind of covers all the bases. It's available easily online, but we were excited to come up with these definitions. So here are some of the worsened health outcomes that we talked about. And I invite you to, copy these slides, they're a good defense and to build support for the different things that food can help. We were hearing about just after lunch, the different ways that food can help different outcomes and worsened health outcomes of food insecurity. So these programs were ones that we concentrated on. SNAP, which we were hearing Richard talk about, produce prescriptions, where there's been a lot of exciting movement and growth in produce prescriptions, and a huge amount of research. If you're looking at a pyramid, the foundational research, there's so many more studies into produce prescriptions than anything else because it's the most widespread. They're the least expensive. They are exciting, and they're feel good for a lot of places that implement them. The actual data, it's a more of a mixed picture, but there's lots and lots of studies on produce prescriptions. The Older Americans Act Nutrition Services Program, which was new to me. Is it new to you, or is it something the Older Americans Act? No, it's so important, and I was just an idiot not to know about it. And then, of course, WIC, which is really the oldest and best established and the most important of these. So here are some of the main findings we came up with: weight status, self-reported health status, and diet quality. Higher rate of obesity among SNAP participants, partly because we thought the idea that they had more access to food when compared with eligible non-participants. So it's hard to pin individual results to the actual causes. That's what we're trying to do in this overview, and in our updated research, which has been the last 3 or 4 years of studies that will be coming out in April. We've got a different, an adjusted set of conclusions from this. So in WIC, here's why WIC is such an important program to us. And then recommendations. So as Elizabeth is a battle-scarred veteran, having been to our Boston meeting in which we spent a lot of time going over and over the recommendations, there's been a lot of exciting momentum around food as medicine in the years since we began. And I guess we began in 2018. Mary hasn't been with us forever. Mary Castillo here. It's just nothing happens without Mary, and so I look at her for the answers to everything. But it was still there were a few centers of research. Mariana will remember all this. And Hilary Seligman at University of California at San Francisco, and Seth Berkowitz now at UNC in Chapel Hill, but then at Harvard Children's Hospital. They were the national leaders in trying to say, here's what medically tailored meals can do for A1C levels, for diabetes rates, for adolescent mental health even, just very early studies into this. But it's since been joined by so many more researchers, so many more studies. There's been so much momentum. We had 26 recommendations in our first report. We couldn't resist, even though I kept trying to get my collaborators to resist, because I think the more concise you are, the fewer you've got, the more they'll land. And I think we're down to 20, maybe. I think we're down to 20 in the current one. But they're quite revised because the NIH has gotten into the act and they say they really want to fund this research. It was just a gleam in the NIH's eye when we began. We're very fortunate that when they put out a request for information and entries in their Centers of Excellence for Food as Medicine proposal, our report is very extensively quoted and actually credited, a rare thing. So these recommendations have been quite impactful for the NIH, which gratifyingly says they make everybody read our report first. It's just because collaborators were very good at presenting tables, and we got a really good designer to present tables, and we've got one for the next. So here are some of the main, not all, of the recommendations we had in the first. A lot of it really focuses on more investment federally for this kind of research, more investment in meals. And I don't know how many of you have applied for or used 1115, 1115 waivers in order to provide meal in states. I see one hand. There are 8 active ones now. There's a dozen more in the pipeline for states that are applying to this. But this is now a very delicate and pivotal moment for food as medicine funding, because if the research isn't well evaluated, and common metrics are a huge part of our new set of recommendations, and I think some of you are involved in data evaluation and presenting evaluation of studies. Coordinating those evaluators nationally is kind of crucial, because without strong data that's coherent and matches state by state the same sort of criteria and the same sort of methodology, the case for increased federal meal assistance could be weakened. And right now it's an incredibly exciting time because of the number of waivers that are already in effect. The main ones have been, you probably have heard about this, Massachusetts, California, North Carolina had some of the strongest data. Mariana's going to come on and correct me because she probably has all the states at her fingertips, knowing where all the waivers are. And Trina is just going to completely update all of this. But the idea is that the more there are, the more possibility there is for health improvements based on medically tailored meals, medically tailored groceries, and reimbursed food. Payers, healthcare payers and healthcare systems, which are beginning, and it's increasing the number of healthcare systems that are working in this. Humana, locally here, Kaiser in California has really been the national leader in this. But they all need good data, because without good data to show about health outcomes, the case is weaker. And as you're probably all aware, the strongest data is from the most severely ill patients. So it's already a skewed, because that's the quickest result. So it's already a skewed data group. The real argument for medically tailored meals and for nutrition assistance is the long-term savings to the healthcare system, the long-term improvements to health. But as Richard and all of you who work with politicians know, that's not a winning argument with politicians because that doesn't help them in the next election. So there's a big challenge before researchers and evaluators in building a case for these kind of interventions. And what we're trying to do is help organize and build this case, and we've been very lucky. And all of you are in the field and you're doing this better. We're building on your work and trying to present it in a compelling way. So I'm glad to answer any questions I can. I'm going to field them all to Trina right now for next. And Elizabeth, but it's been very exciting to watch the growth in food as medicine. And what Alyssa was describing has been a long trajectory. It's 35 years now. But really in the past 5 years even that we've been working on this, there's been huge growth. Even in the term food as medicine or food as medicine, people have strong opinions on which it should be. But it's a time of growth and potential and excitement. And we're very lucky to have gotten to a ringside seat. And we're looking forward to the release of our report in April. So thanks for the chance to present it.
Thank you so much.
So, any questions I can fumble? Anything? There's one there.
Kind of a philosophical question that I'd be interested in anybody's response. We use the term medically tailored meals. If you take like the Mediterranean diet, which has good evidence, and culturally adapt it, I think that's most, like the American Heart Association, diabetes would all say that's a healthy meal for that condition. So when we call it medically tailored meals, it seems to kind of take away the fact that it's a generally healthy meal for a healthy population. I mean, it would be a huge change to not use that, but it seems to medicalize it. I know food is medicine medicalizes it, but why don't we call it healthy meals? Some medically tailoring is necessary for like renal diets and things like that, but.
Well, how often do you see common sense prevailing in the medical field or in legislative writing? Of course, that's all true. And I, who spent my life as a food writer, certainly never believed in the medicalization of these terms. But medically tailored meals has acquired this snowballing momentum and funding. And when you say the Mediterranean diet, I have to think of, I teach at the Tufts Friedman School of Nutrition. In fact, I was just teaching for an hour right before this, and one of my students spent the entire time, she's African American, saying, the Mediterranean diet is so tailored for white Europeans. What a ridiculous, culturally insensitive term. But in fact, she believed in the general principles of, the DASH diet. There are some very common sense, general dietary guidelines that I think everybody would agree is healthy. The pyramid that went out before my plate. All of these general guidelines, absolutely right. Now I'm going to put on the hat of a board member of Community Servings. So the groups that Alyssa was talking about, her Food is Medicine Accelerator, would make the argument that they have no fewer than 32 individually tailored meals depending on the comorbidities, the different diseases. Who was it who said just earlier that or maybe it was Alyssa, no fewer than 4 diseases among the client population at the beginning? So those agencies are very huffy and defensive as well as proud of the fact that when they give meals to clients, it's very specifically tailored to the health metrics they took the time to gather. That's so expensive and requires so much person power that it's probably not the wave of the future. The wave of the future is going to be generally healthy meals produced as efficiently and on as wide a scale as possible. That's what I think is going to be the winning argument. But that's part of the origin of that medicalization of the term.
Thank you. That's great. And quick note on Mediterranean diet, because I get that question a lot too. We've developed what we call the Med-South diet, which is taking the principles of the Mediterranean diet. So you can take those principles of healthy oils, nuts, vegetables, and apply them to any culture. That's where people get, you don't have to eat grape leaves to eat the Mediterranean diet, and I think people are confused about that.
That's just where my student landed, so you're now a review reader for her paper. Thank you very much. Oh, one more. Or maybe two.
Or two more.
I had not heard the statistic of higher rates of obesity for folks who are on SNAP versus folks who are eligible but non-participating. The same does not exist for WIC, correct? It's not a same statistic?
I don't think so. And what I remember is there are a lot of potential confounding factors of that. But I have to say there was a very carefully controlled study in Hartford, Connecticut in the past 2 years, and it shows a similar discouraging result. But keep going.
Oh, similar. I was just curious what the, if the role of the limitations of the purchasing with WIC had an impact compared to SNAP.
You're so good at bringing up these third rail subjects. So, there is a whole school who would love to impose WIC-style regulations on SNAP. I don't think we're going to live to see it in our lifetimes, so I'm happy to debate it over dinner, but I just don't think it's ever going to happen, especially when you look at the market basket of most non-SNAP participants compared. They're so similar. So, no, but that was not one of the theories. This was about the way SNAP was provisioned and the eligibility and economic possibilities of the families that were on it, as I recall.
Got it. Thank you.
I had some of the same questions. Very interesting. And I'm wondering also if it doesn't have to do with the fact that SNAP only provides such a limited amount so that your people are often buying highly
Caloric, hypercaloric.
Yeah, they're not able to, and that's why, double up food bucks and all those other programs exist. So, but my question is on the evaluation part. Wouldn't it be interesting? So I know from the USDA, all the partners that are funded by USDA GusNIP programs, for instance, including the produce prescription program, we are being asked to evaluate similarly and contribute our data on a national basis so that there can be some common lessons learned. So I'm wondering, can't NIH and CDC and USDA and whoever else get together and maybe not them, but contract with somebody with a similar kind of entity to do common evaluation across some of the programs that are looking at this so that they get similar data?
Again, you're applying common sense where so little prevails. That's actually number one on our new set of recommendations. These agencies should talk to each other and share data. Another one is that there should be a convening of all the different evaluators to try to even settle on the same platform, because there are several rival data platforms for reporting, and that should be coordinated too. So you're absolutely right. The good thing of what you just said is that the SNAP provisions come with a requirement of reporting data, but how it all gets mixed together, and there's so much data that NIH and CMS and HHS and CDC, they all have similar overlapping pools, and no one, to my knowledge, is adequately coordinating them now. So we do think that would be a wonderful idea.
Is it okay if
I want to reassure you that NIH is trying to do that actually, where they're, through one of their current initiatives, their funding initiatives, are looking to fund 21 teams across the U.S. that had been previously doing CBPR, community-based participatory research around COVID. All those teams are being asked to pivot to general health promotion in the communities in a very community-intensive fashion, and all teams are being asked to use a common survey to evaluate that work as part of their evaluation. And WestStat, I believe, is the
Let me just say, I have to talk to you about this, because one of our main recommendations is to emphasize qualitative as well as quantitative research, and these
And I
people
agree
are
with
going to
you
know
on
how to do it.
So, but anyway, it seems like they're at least heading in that direction. This was the first time I had heard of NIH kind of imposing on academic researchers like myself that you will measure your intervention in this way. I think typically they've wanted to give us, that academic freedom, but that's not always a good thing.
They need to talk to the USDA to get it.
Yeah.